Two competing pharmaceutical representatives have met with staff at Macquarie University Hospital Pharmacy to convince the head chemist to invest in their drugs. He has called a meeting between the both of them and his assistant chemist. Good morning, everyone. My name is Hamam, and I'm the head chemist at this pharmacy. This is my assistant, Reen.
Hi guys, my name's David. I'm a pharmaceutical rep from Arrow Pharmaceuticals.
My name's Bailey. I'm a pharmaceutical rep from Secris Pharmaceuticals.
Nice to meet you. Now, what do you have for me?
Well, I'd like to introduce you to Tramadol. It's a well-established opioid medication that's used for moderate to severe pain. Have you heard of it before?
No, I haven't. Could you talk more about it?
Yeah, of course. Let me just start by telling you how it kind of works. It's pharmacodynamics. So, Tramadol actually has a dual mechanism of action. It works as both a serotonin and norepinephrine reuptake inhibitor, but it has its main analgesic properties through its mu-opioid receptor agonism. So, mu-opioid receptors are essentially GPCRs located in the nociceptors, which are part of the ascending pain pathway, essentially the nerves that tell your brain when you're in pain. Now, typically in a normal firing, when an action potential reaches the presynapse, it causes voltage-gated calcium channels to open, allowing the influx of calcium into the neuron, which will then cause glutamate or other neurotransmitters to be released into the synaptic cleft, which will then go and interact with ion channels on the postsynapse, causing them to open, allowing ions to rush into the postsynapse, the next nerve, allowing propagation of the action potential. However, when our mu-opioid receptor agonist binds, it will cause the dissociation or the activation of our transducer G proteins, such as G-alpha-I or G-beta-gamma. Now, in the presynapse, G-beta-gamma will actually interact with these calcium channels and prevent them from opening, meaning even when an action potential reaches the presynapse, calcium doesn't rush into the cell and it prevents the release of glutamate and other neurotransmitters out of the cell. In the postsynapse, the G-beta-gamma protein will actually interact with something called GERK proteins, which are essentially potassium channels which will efflux potassium out of the cell. So it causes these potassium channels, such as KAR3, to open and push potassium outside the cell. And the effect this has is basically making it much harder for the cell to depolarize, even if a little bit of neurotransmitter is able to get across the synaptic cleft and open up the ion channels. As more and more positive ions rush in, constant pushing out of potassium will make it much harder for that action potential to reach threshold and go down the neuron. Whilst this is happening in the postsynapse and the presynapse, in both of these post and presynapse, we actually see the G-alpha-I, the inhibitory alpha subunit, will go off and interact with adenylyl cyclase, and this will essentially inhibit adenylyl cyclase, stopping the catalytic reaction of ATP into cyclic AMP, which is a secondary messenger which will activate different kinases, which will go and phosphorylate different transcription factors to go and basically upregulate the pain signals being sent to the brain. So essentially, this will have an inhibitory effect on the whole ascending pain pathway, making it harder for the body to receive those pain signals. Now, while this is just the general mechanism for mu-opioid receptor agonism, Tramadol is actually only a partial agonist and is much less potent to morphine and tapentadol.
I've been reading a lot about how Tramadol also acts as an SNRI. Can you please explain more about this concept?
So Tramadol also acts as an SNRI. It blocks the reuptake of serotonin and norepinephrine by inhibiting the transporters that pull it back into the presynapse. This helps reduce and dampen the pain signaling being sent to the brain, and it can also contribute to mood modulation.
Thank you, David. Bailey, could you please provide some insight into how Tapentadol's pharmacodynamics differ from Tramadol's?
Well, Tapentadol's pharmacodynamics doesn't differ a lot. It does have a very similar mechanism of action to Tramadol, but it does not function as a serotonin reuptake inhibitor. So we use it as a very powerful opioid analgesic for moderate to severe pain. Tapentadol is also much more potent than Tramadol. It is also a full agonist of the mu-opioid receptor, meaning it is a lot more efficacious than Tramadol.
David, can you please elaborate on the pharmacokinetics for Tramadol?
Yeah, of course. So Tramadol is actually quite well absorbed when taken orally. It has an oral bioavailability of roughly 68 to 72%, and it has an approximate volume of distribution of 2 to 3 kilograms per litre, meaning it is relatively lipophilic and it has quite a good tissue distribution throughout the body. Its main metabolic pathways are through O and N demethylation, followed by conjugation from gluconides by different cytochrome P450 enzymes, such as CYP2D6 and CYP3A4.
Bailey, what is different about Tapentadol's pharmacokinetics?
Well, Tapentadol is similar in the fact that it's an oral drug that is rapidly absorbed after administration. However, it does have a lower bioavailability than Tramadol, sitting at 32%, but this is due to excessive first-pass metabolism. Tapentadol, however, is much more lipophilic than Tramadol, with an approximate volume distribution of 8 litres per kilogram, being more widely distributed throughout the body.
How does tapentadol's major metabolic pathway differ from tramadol?
Unlike tramadol, tapentadol is an active drug with no active metabolites. Phase 2 conjugation plays a very major role in the metabolism of tapentadol. As we can see, the major inactive metabolite of tapentadol, tapentadol O-glucuronide, is metabolized by the transferases UGT1A6, 1A9, and 2B7. It also has an inactive metabolite, the minor variant of tapentadol O-sulfate, metabolized by the transferase SULT. Phase 1 reactions play a far less important role in the metabolism of tapentadol.
Could you please explain the excretion of tapentadol?
Of course, it's very similar to tramadol. 99% of tapentadol and its metabolites is excreted through the kidneys.
Thank you both for providing insight into tramadol and tapentadol's pharmacodynamics and pharmacokinetics. I think I'm going to choose to invest in tapentadol.
Excellent. Thank you for the time, mate.
Yeah, thank you.
Humam and Reem have a chat after the meeting. She's curious about his investment choice.
Why did you choose Tapentadol over Tramadol?
Because tramadol is a prodrug, its metabolism can vary among different individuals due to differences in short nucleotide polymorphisms. So this could reflect especially on the activity of the CYP26 enzyme. Some individuals may be poor metabolizers, others extensive metabolizers, and others ultra-rapid metabolizers. Poor metabolizers can experience decreased pain relief, while ultra-rapid metabolizers may experience an increase in side effects or even toxicity due to rapid metabolism. So tapentadol has a more predictable metabolism and there is less risk of variability in response.
I'll keep all these points in mind in the future if I do encounter Tramadol.
After stalking tapentadol, Reem goes through its product information. She has a few thoughts.
I need to understand Tapentadol's half-life and time to reach steady state, so I can relay this information to our customers. Tapentadol's half-life is approximately 6 hours. This means it takes about 6 hours of half the administered dose to be eliminated from the body. Typically, it takes about 3 to 5 half-lives for a drug to reach steady state, plasma concentration. This means that Tapentadol's steady state is reached after 18 to 30 hours. In its sustained release from Tapentadol is to be taken twice daily, approximately every 12 hours. This should provide our customers with steady pain relief throughout the day.